بسم الله الرحمن الرحيم. عندنا الموضوع اللي هنشوفه النهاردة الديبريشن والمانجمنت of depression by antidepressants. الديبريشن it is called also affective disorder. The affective disorder are considered to be the second major class of psychosis, and they are characterized primarily by mood changes rather than thoughts disorder. تمام؟ يبقى لما اقول affective disorder this mean depression and other disorder which are related primarily to mood changes rather than thoughts disorder. This affective disorder is include major depression, mania, and manic depression illness when there is a shift between mania and depression. We will talk about the major depression in this lecture. The major depression symptoms include sustained depressed mood, loss of interest in activity, appetite and weight changes, loss of energy, and suicidal thoughts. دي the main symptoms of depression. لما جينا نشوف الاتيولوجي أو reason or the causes of depression لقينا إن مش does not obey certain causes but mainly theories. Depression is thought to be associated with monoamine neurotransmitter deficiency including norepinephrine and 5-HT or serotonin. Mania is related to monoamine hyperactivity. What is against this monoamine theory? That tricyclic antidepressant inhibition of monoamine reuptake occurs rapidly unlike slow mood elevation. يعني دايما management of depression بتاخد وقت طويل علشان تديني الإفكت بتاعها. فلو هنمشي على الثيوري دي هنلاقي ان في tricyclic antidepressant does not obey this theory. Why? Because it will result into inhibition of monoamine reuptake in very short time unlike the other antidepressants which result into slow mood elevation. تاني حاجة against the monoamine theory that some new antidepressants are monoamine independent. They exert their action by other mechanism rather than the monoamine theory. The available antidepressant in the market we will start by the selective serotonin reuptake inhibitors, which is the first line actually for management of depression. يعني لما بيكون عندنا أي حد بيسافر from depression أول دراج بنفكر فيه هو selective serotonin reuptake inhibitors. الميكانيزم بتاعه إن هما بيكونوا selective blockers of 5-HT transporter 3000-fold greater than norepinephrine. يعني they are very specific and selective for 5-HT transporter. They exert a very weak antagonist effect on muscarinic, histaminergic and alpha-adrenergic receptors, and it will result into low or no anticholinergic side effects, sedation or hypotension. تمام؟ أدام هما ليهم very weak blocking effect on muscarinic, histaminergic and alpha-adrenergic receptors يبقى الليفل بتاع السايد افكتس على طول بتاعهم هيقل، فبالتالي مفيش انتي كولينرجيك سايد افكتس سيديشن او هايبوتنشن. الاكزامبلز بتاعهم في عندنا فلوكسيتين، سيتالوبرام، فلوفوكسامين، باروكسيتين، ايسيتالوبرام and sertraline. And you must take into consideration that escitalopram is a pure escitalopram enantiomer. السيتالوبرام نفسه هو البيرنت دراج وبعدين عملنا منه البيور ايسيتالوبرام اللي هو البيور اس انانتيومر which exert its activity more than the parent one which is the citalopram. هنا بيورينا المود اوف اكشن. طبعا بصنفه ان هو serotonin reuptake blocker increase 5-HT as a synaptic left and prevent the subsequent degradation of serotonin, and so it will increase the postsynaptic neuronal activity. And its antidepressant mood elevation take about 2 weeks to develop and more than 12 weeks to reach the maximum response in persons. زي ما احنا شايفين هنا في الفيجرز. الفيجر بتوريني ان انا هنا عندي اللي باللون البلو ده هو السيروتونين بنلاقي ان المفروض ان السيروتونين لما بيحصل له ريليز بيبقى باي سيرتن ترانسبورتر بيحصل له ري ابتيك تاني. فاللي بيحصل ان وجود السيروتونين سيلكتيف ري ابتيك انهبيتور بيبلوك الترانسبورتر and so it will increase the availability of serotonin receptors in the synaptic cleft and it will exert its action in the postsynaptic membrane. Regarding the time, it will take 2 weeks to develop and more than 12 weeks to reach its maximum response. The therapeutic uses of serotonin selective reuptake inhibitors, it is used for major depression, obsessive compulsive disorder اللي هو الوسواس القهري, panic disorder, generalized anxiety and in case of premenstrual dysphoric disorder. طبعا عارفين ان قبل المنستريشن الفيميلز بتتعرض لcertain psychological disturbance, فبالتالي بقدر ان انا ممكن في الاكزاجريتد كيسز ان انا ادي الدراج ده. طب what are the adverse effects of serotonin selective reuptake inhibitors? We have two main side effects, the sleep disturbance and sexual dysfunction. The first one, which is the sleep disturbances, we have that paroxetine and fluvoxamine are sedating and they are useful for poor sleeping patients. يعني في ايه؟ في ناس يجيلهم depression وما يجيلهمش نوم، فلما اجي اختار انتي ديبريسنت اختار الحاجه السيديتنج اللي تقدر ان هي تخليهم يناموا كويس للناس اللي عندهم انسومنيا، فبضطر ساعتها اديهم يا اما باروكسيتين يا اما فلوفوكسامين. مهمين قوي الحاجات دي يا جماعه. طيب في الناس اللي بيجيلهم ديبريشن مع دايما sensation of fatigue، ساعتها هديهم activating antidepressants like fluoxetine which are better for patients having fatigue. تاني حاجة عندي sexual dysfunction which is characterized by loss of libido and ejaculation failure. بقدر ان انا في حالة ان البيشنت بياخد السيروتونين selective reuptake inhibitors ببدله بتو دراجز تانيين mainly الميرتازابين والبروبيون، او ممكن ان انا ريديوس الدوز او استخدم فوسفودايسيريز 5 inhibitors. يبقى انا عندي السكشوال ديسفانكشن اقدر اعمل توتال دراج ريبليسمنت او اريديوس الدوز او اكومباين معاه الفوسفودايستريز انهبيتور. What about their use in children and teenagers؟ بنلاقي ان هما لما بيستخدموا في البوبوليشن دي ان هما increase suicidal tendency in children, so monitoring depression and the suicidal tendency is very important and recommended after drug initiation or dose increase. طيب in case of overdose of serotonin selective reuptake inhibitors be result into serotonin syndrome which can occur in presence of MAO inhibitors especially, and it will result into hyperthermia, muscle rigidity, changes of mental status and vital function. And so we recommend the long washout period before starting other drugs, especially with long duration agents as fluoxetine. يبقى دايما يا جماعه لما باجي سي ان انا لقيت في دراج من الانتي ديبريسنت مش افكتيف زي فور اكزامبل الماو انهبيتور واجي ادخل سيروتونين سيلكتيف ريابتيك انهبيتور، لازم ان انا يعني اعمل ويزدرول للدراج الاولاني قبل ما ادخل التاني. يا اما لو انا بستخدم اصلا السيروتونين سيلكتيف ريابتيك انهبيتور وعايزه ادخل معاه الماو انهبيتور، لازم ان انا اقلل الدوز بتاع السيروتونين selective reuptake inhibitor by long washout period before starting the other drug which is for example the MAO inhibitor. It is relatively less toxic than tricyclic antidepressant and it could be used safely in patients suffering from cardiovascular disorder. The second one is the serotonin norepinephrine reuptake inhibitor like venlafaxine and duloxetine. Selectively block reuptake of both norepinephrine and 5-HT. الأولاني كان 5-HT بس. So it is effective in patients suffering from serotonin selective resistant depression. يعني البيشنت اللي عنده depression واستخدم السيروتونين selective reuptake inhibitor ما جابتش نتيجة، فبشيفت على serotonin norepinephrine reuptake inhibitor. It will restore the level of 5-HT and the norepinephrine in the synaptic cleft by binding at the reuptake transporter, and so it will prevent the reuptake and subsequent degradation. This reuptake blockade lead to accumulation of monoamine in the synaptic cleft and the concentration return to the normal range. Similar to tricyclic antidepressants, they are effective in relieving depression-related neuropathic pain where norepinephrine and 5-HT reuptake inhibition is required. من الحاجات الكويسة ان هو ملوش اكشن على الماسكارينيك H1 and alpha adrenergic receptors، فبتوقع انها هتبقى side effects بتاعته just GIT side effects and it will be more with duloxetine, and the sexual dysfunction also will occur or highly prevalent in duloxetine rather than the venlafaxine. Regarding the tricyclic antidepressant, we have two drugs. The first one is the tertiary amines and the second is the secondary amine. بالنسبة للترشري امين الاكزامبلز اللي عندنا الإيميبرامين، أميتريبتايلين، كلوميبرامين، دوكسيبين and تريميبرامين. Regarding the secondary amine, we have desipramine, nortriptyline, maprotylene and protriptyline. All have similar therapeutic effects but differ with each other regarding the duration of action and the side effects tolerance. The patient not responding to one tricyclic antidepressant can respond to another. They are alternative to serotonin selective reuptake inhibitors resistant patients. يبقى ده اللي بيورينا ايه يا جماعه؟ ان انا اهم دراج ابتدي بيه هو serotonin selective reuptake inhibitors. In case of resistance يبقى بشيفت to the second class which is serotonin norepinephrine reuptake inhibitors or tricyclic antidepressants. هنا ده الميكانيزم اوف اكشن، ان هو بنقول ده نون سيلكتيف، فبنلاقي ان هو بينهبت، شايفين هو اللي لونه اصفر الترايسايكليك انتيديبريسنت، بينهبت the reuptake of 5-HT of noradrenaline and it will exert of course side effects on muscarinic receptors, histamine, adrenergic and serotonin receptors, and so it will exert pharmacological action and the therapeutic effect on serotonin receptor and noradrenaline receptors and certain side effects on other receptors. So tricyclic antidepressants bind to 5-HT norepinephrine reuptake transporter and so prevent the reuptake of norepinephrine and serotonin from the synaptic cleft and their subsequent degradation. This reuptake blockade leads to the accumulation of serotonin and norepinephrine in the synaptic cleft. They are non-selective inhibiting norepinephrine and 5-HT uptake to a similar degree. The side effects atropine-like effects طبعا عشان الإفكت بتاعه على الماسكارينيك ريسبتور، postural hypotension, alpha-1 adrenergic receptor block, sedation due to histamine receptor blockade, poor dental health due to its effect on salivary secretion. طبعا انتوا عارفين ان وجود السلايفا مهم جدا عشان الدنتال هيلث، فلما بقلل الساليفري secretion due to its atropine like effect اللي هي dry mouth، بنلاقي ان في poor dental health. The cardiovascular side effects of tricyclic antidepressant are due to catecholamine uptake inhibition and kinidine-like action. It will result into heart failure and ECG changes, hypertension or hypotension according to the situation, and tachycardia, more likely in cardiovascular patients. Tricyclic antidepressant have a narrow therapeutic index، ودي من الحاجات المهمة جدا. Imipramine lethal dose is only 5 to 6 folds of its maximal dose. The drug interaction tricyclic antidepressant with MAO inhibitor result into hypertension, hyperpyrexia, and convulsions. Tricyclic antidepressant with sympathomimetic amines enhance the effect of biogenic amines and it will result into hypertensive crisis. Tricyclic antidepressant with other CNS depressant can result into toxic sedation. يبقى احنا عندنا لازم نخلي بالنا من حته ان الترايسايكليك انتيديبريسنت ليه نارو ثيرابيوتيك اندكس، يعني لو الدوز زاد لاي سبب ممكن ان هو يدخل في توكسيستي. تمام. وطبعا الدراج انتراكشنز معظمها will result into hypertension and hypertensive crisis and when it is given with other CNS depressant will result into toxic sedation. The monoamine oxidase inhibitor, which is the fourth class of antidepressant, we have phenelzine and trenylcypromine, isocarboxazide and siligilene. The MAO enzyme will regulate both free intraneuronal concentration and the releasable stores of serotonin and norepinephrine. It binds covalently to the MAO non-competitive irreversible inhibition, and they inhibit the two isoenzyme MAO A and MAO B. This will result into greater stores of monoamine available for release. يبقى لنا هنا الدراكس دي بتشتغل هنا انه once ان حصل reuptake ما بيحصلهاش degradation and metabolism by MAO, and so when it is released it will also inhibit the metabolism بتاعها, and it will exert its beneficial effect on 5-HT receptor and noradrenaline receptor in the postsynaptic membrane. The therapeutic effect of MAO inhibitor is associated with MAO A inhibition. Phenelzine and trenylcypromine are non-selective MAO inhibitors. Side effects of MAO inhibitors, we have hypotension, atropine-like side effects, weight gain and excessive CNS stimulation. تمام. وفي كمان لازم ناخد بالنا من حاجة، ان المونو امين اوكسيديز انهبيتورز مش بس بينهبت الماو ان ذا برين، لكن بينهبت الماو كمان في الليفر and the gut, which catalyze oxidative deamination of drugs and potentially toxic substance like tyramine which is found in certain food. وطبعا المعروف ان التيرامين موجود في انواع من الجبن اللي هي الجبنة اللي بتبقى حادقة شوية وقديمة. So the MAO inhibitors therefore show a high incidence of drug and drug-food interaction. ونخلي بالنا ان السيليجيلين given as transdermal patch because it can produce less inhibition of gut and hepatic MAO at low doses because it avoid the first pass metabolism. Inhibition of MAO زي ما قلنا in the brain مش بتحصل بس في البرين، بتحصل في الليفر وبيكاتالايز الاوكسيديتيف deamination of drugs and potentially toxic substance like tyramine found in certain food. MAO show high incidence زي ما قلنا of drug and drug-food interaction. Siligilene administered as transdermal patch may produce less inhibition of gut and hepatic MAO at low doses because it avoids first pass metabolism. Siligilene and trenylcypromine have an amphetamine-like stimulant effect that may produce insomnia in patients taking these drugs. Phentolamine and prazosin are helpful in the management of tyramine-induced hypertension. These drugs are well absorbed after oral administration. Enzyme regeneration when irreversibly inactivated varies, but it usually occurs several weeks after termination of the drug. يعني regeneration of the MAO enzyme بتحصل بعد لما بنعمل stopping of the drugs by several weeks. مش وقفته على طول هيحصل regeneration of the activity of the enzyme. Switching antidepressant agents, a minimum of 2 weeks of delay must be allowed after termination of MAO inhibitor therapy and the initiation of another antidepressant from any other class. يبقى لازم يا جماعة لما اعمل سويتش لازم استنى 2 ويكس ابتدي اعمل withdrawal، واستنى 2 ويكس قبل ما ابتدي اعمل initiation of another antidepressant from any other class. A typical antidepressant we have bupropion, mirtazapine and nifazodone and trazodone. Bupropion is a weak dopamine and norepinephrine reuptake inhibitor. يبقى weak drug, weak antidepressant. Bupropion is useful for decreasing craving and attenuating withdrawal symptoms of nicotine in patients trying to quit smoking. وده هنشوفه اكتر في المحاضرة بتاعة CNS stimulant. يبقى عندنا البوبروبيون بستخدمه كأنتي ديبريسنت، وليه يوز تاني ان انا بستخدمه to decrease cravings and attenuating withdrawal symptoms of nicotine in patient trying to quit smoking. طب ايه هي side effects بتاعته؟ dry mouth, sweating, nervousness, tremor and dose dependent increased risk of seizure. It exerts a very low incidence of sexual dysfunction على عكس السيروتونين selective reuptake inhibitor. Should be avoided in patient at risk for seizures or having eating disorder such as bulimia. طبعا عارفين ان في ناس بتسافر from eating disorder. البوليميا دي اللي كانت بتسافر منه الأميرة ديانا ان هي كان بيبقى عندها sensation of guilt او ذنب لما بتاكل، فبعد لما بتاكل بتعمل induction، بتحط صباعها في اخر الحلق بتاعها وبتنجوز الفوميتنج بتاعها. فطبعا انا ما اقدرش ان انا ادي البيشنت who suffer from bulimia البوبروبيون. خلي بالكم البوبروبيون من الحاجات المهمه، لازم ابقى عارفه ان هو ويك دوبامين اند نورابينفرين ريابتيك انهبيتور، ان هو بيديكريز الكريفنج للناس اللي عايزين يبطلوا تدخين. سايد افكتس ان هو في حاجات اتروبين لايك افكت زي دراي ماوث، لكن فيها بيعمل سويتنج نيرفسنس تريمور. وبنخلي بالنا ان هو بيexert very low incidence of sexual dysfunction and should be avoided in patients with risk of seizures or bulimia. الميرتازابين it is a noradrenergic and specific serotonergic antidepressant. It have a dual mechanism of action that increase the concentration of serotonin and norepinephrine. يعني من الآخر لازم ان هو يزود لي concentration of norepinephrine and serotonin. They bind and inhibit presynaptic alpha-2 receptor also, and this will prevent the negative feedback effect of synaptic norepinephrine on 5-HT and norepinephrine neurotransmission. These drugs also block 5-HT2 and 5-HT3 receptors on the postsynaptic membrane, and this will cause enhanced 5-HT1 mediated neurotransmission. It is approved, of course, by the Food and Drug Administration, and it is virtually devoid of atropine-like effect, 5-HT related side effects, and adrenergic side effects like orthostatic hypotension and sexual dysfunction. The antihistaminic side effects of sedation and weight gain are the most prominent. يبقى الانتيهيستامينيك side effects بتاعه of sedation, which is advantage in depressed patient have difficulty in sleeping, of course, and weight gain are the most prominent effects. It is most useful as an add-on medication in treatment of severe and resistant depression. يعني ما بستخدموش لوحده، لازم استخدمه in combination with any other main class of antidepressants. Nefazodone and trazodone, they are weak inhibitors of serotonin reuptake, and their therapeutic benefit is due to their ability to block postsynaptic 5-HT2A receptor. Both agents are sedating due to their potent histamine H1 blocking activity. Trazodone is commonly used off-label for the management of insomnia, and both agents have mild to moderate alpha-1 receptor antagonism, contributing to orthostasis and dizziness. Selective norepinephrine reuptake inhibitor, we have reboxetine. It is the first commercially available norepinephrine reuptake inhibitor developed specifically as the first-line therapy for major depressive disorder. In vitro and in vivo pharmacological study indicated that reboxetine have high affinity and selectivity for the norepinephrine transporter over the serotonin and the dopamine transporters. We have also the selective norepinephrine reuptake inhibitor restore the level of norepinephrine in the synaptic cleft by binding at the norepinephrine reuptake transporter, and so by this mechanism it will prevent the reuptake and the subsequent degradation of norepinephrine. This reuptake blockade lead to the accumulation, of course, of norepinephrine in the synaptic cleft, and the concentration of norepinephrine subsequently will return to within the normal range. كلهم بيعملوا نفس الميكانيزم بس ب different mode of action. We have also the antidepressant discontinuation syndrome. It occurs in approximately 20% of patients after abrupt discontinuation of antidepressant medication that was taken for at least 6 weeks. يعني لو واحد بياخد الانتيديبريسنت حوالي شهر ونص ووقفته بيبقى بيعمل لي مشكلة اسمها الانتيديبريسنت discontinuation syndrome. Typical symptoms of this syndrome include flu-like symptoms, insomnia, nausea, imbalance, sensory disturbances, and hyperarousal. It is more frequent with serotonin selective reuptake inhibitors and the serotonin norepinephrine reuptake inhibitor. These symptoms usually start mild, last 1 to 2 weeks, and are rapidly extinguished or decreased with reinstitution of antidepressant medication. Antidepressant discontinuation syndrome has the following risk factors. The first one is long duration of treatment. يعني لما بستخدم antidepressant لفترة طويلة واجي بعد كده اوقفه. Shorter half-life antidepressant which is more pronounced with paroxetine and less likely with fluoxetine. يعني في عندي short duration antidepressant like paroxetine and long duration antidepressant like fluoxetine. لو جينا بصينا تو سلايدز كده عن مود stabilizers زي ما شايفين في الفيجر دي ان احنا عندنا ده النورمال مود، وبعدين لو المود قل بيبقى فيه mild depression، لو قل زيادة بيدخل البيشنت في major depression. لو عندي النيورو ترانسميترز حصل فيها بقت دخلته في مود المود زاد فبيبقى فيه هايبومانيا، وبعدين لو زادت قوي بيبقى مانيا. لو البيشنت بيفلكتويت ما بين الاثنين، شويه بيسافر from major depression وشويه from mania، بسميه بيسافر from bipolar disorder. The treatment of bipolar disorder has increased in recent years due to increased recognition of the disorder and increase in the number of available medication for the treatment of mania. زي ما شايفين كده على عكس الديبريسد مود في عندي المانيك مود، نلاقيه زي ما شايفين في الفيجر البيشنت بيتوك rapidly feeling unusually optimistic or extremely irritable، بيبقى sleeping very little، بيبقى فيه insomnia، بيبقى highly distractible يعني يخليك مشتت وانت قاعد بتتكلم معاه. بنلاقيه برضو ان هو بيأكتنج recklessly and impulsively، يعني تلاقيه زي ما شايفين في الصورة بيسوق يروح باصص الناحية التانية فجأة، فيكون بيعمل حاجة يعمل distraction ويبص الناحية التانية. drugs which are used for bipolar disorder في عندي الليثيوم سولت طبعا هو ده المين دراج، وفي عندي الانتي ابيليبتكس زي اللي شفناهم قبل كده كاربامازيبين فالبرويك اسيد اند لاموتريجين. الليثيوم سولت مش عايزاكم تعرفوا اكتر من ان هو بستخدمه for acute and prophylactic bipolar patient and it is effective in treating 60 to 80% of patients exhibiting mania and hypomania. The common adverse effects of lithium: headache, dry mouth, polydipsia, polyuria and polyphagia. برضو السايد افكتس بتاعته gastrointestinal distress and so we must give lithium with food. toxicity بيعمل اتاكسيا يعني بيديكريز الماسل تون، slurred speech, coarse tremors, confusion and convulsions. ولازم ناخد بالنا جدا من النوتة بين الاخرانية ان الليثيوم is renally eliminated and caution should be considered when using it when dosing this drug in renally impaired patients and because elimination هتقل فالليثيوم هيexert toxic effect. فلازم نخلي بالنا كويس جدا من لما بستخدمه مع اي patient بيسافر from any renal disorder.